and welcome to the ISTH World Thrombosis Day Ask the Expert series. Today we're excited to discuss the very important topic of women's health and thrombosis and include gender-specific risks. Now, while we know that men have higher risks of blood clots in the whole of their lives, there are periods in women's lives where they have much higher risk than men, and those include pregnancy, the use of birth control, and hormone replacement therapy. So today we're going to discuss these risks and discuss what you need to know for proper prevention and treatment. So I'm your host, Professor Beverley Hunt, Chair of the ISTH World Thrombosis Day Steering Committee. I'm a Professor of Thrombosis and Hemostasis based in London at King's College, and I'm a consultant at a thrombosis unit at Guy's and St Thomas's Hospital. I'm really pleased to welcome my colleague, Professor Claire McLintock, from the other side of the world. She's a clinical and laboratory haematologist based in Auckland, New Zealand. And she also serves alongside me as Vice Chair of the World Thrombosis Day Steering Committee. She's also a former president of the ISTH. And luckily, Claire does specialise in women's health and thrombosis, specifically focusing on obstetric medicine. Claire, it's great to be with you today.
Lovely to be here.
So we understand there's quite a lot of information about gender-specific thrombosis, and I'm really looking forward to learning more today. As an important note for our viewers, we are providing general information only. If you have specific questions about you, please consult with your healthcare professional. Okay, let's get started. So, Claire, can you share with us when women are at increased risk of developing blood clots?
So if we think about women specifically, rather than generally in terms of general risks of thrombosis, such as surgery or whatever, the major times that a woman is at risk of thrombosis are if she is considering birth control, in particular combined estrogen-progesterone birth control or the combined oral contraceptive pill. Obviously, when she's pregnant is another time when she's at an increased risk. And then later in life, if a woman chooses to use hormone replacement therapy, menopausal hormone replacement therapy, then that's another time when the addition of exogenous hormones increases her risk of blood clots.
Great. So shall we focus on one in particular? Let's look at the combined oral contraceptive pill. What is it in the pill that makes women at risk? And are there alternatives that they can use safely and comfort?
Yeah. Well, importantly, there are a number of different types of contraceptives. You've got the tablet form of contraceptives, which broadly speaking splits into those that combine estrogens with progesterones or those that have progesterone only. And studies have definitely shown that it is the combination of an estrogen and a progesterone that leads to the increased risk of thrombosis in women. And importantly, progesterone-only pills are not associated with an increased risk of thrombosis. What it is about the estrogens is probably that they increase the amount of pro-clotting factors in the blood, making a woman's blood a bit more sticky or a bit more clotty. And what we also know is that the different types of estrogen progesterone contraceptive pills have different risks. The first type that were introduced, they're now so-called second generation estrogen progesterone combination pills, increase your background risk of blood clots by 2 to 3 times, which can sound quite scary actually, but you've got to remember that the background risk overall in that population is probably about 1 in 10,000. So by taking a second generation pill, you'll increase your risk to about 2 to 3 in 10,000 in the general population. If you take a third generation pill, the risk is increased further to about 5 to 10-fold. So again, that's 5 to 10 per 10,000 cases. So up to about 1 in 1,000 highest risk with the third generation progesterone-only pills. And there are some other fourth generation ones, especially not the progesterone only, the combined pills, but there are some other forms of contraception with more androgenic types of hormones, which are thought to be the higher risk or the highest risk of clotting. But trying to find the right pill to suit you the best is the most important thing, because one of the critical aspects about contraceptives is that they enable you to help plan your pregnancies. So to choose the time when becoming pregnant suits you best. So the important thing to do is to have a discussion with the woman about which pill might suit her, start her on the lowest risk pill. And if that one isn't suitable, doesn't suit her body physiology, then you might have to go for a third generation or even a fourth generation pill. So it's important that when you discuss the type of pill with the woman, you discuss the clotting risk, and importantly, explore what a woman's clotting history may have been, or what her family clotting history may have been. Because a woman who's had a previous clot shouldn't take a combined pill without any anticoagulation. And a woman with a family history, you need to explore that carefully to find out how important that family history will be for that specific woman and her choice of contraceptive pill. But the other important thing is to remember that there are other contraceptives. We have the intrauterine devices that release progesterone, which are absolutely safe for the risk of blood clotting. So that's a really good option. Or the implantable progesterone releasing rods, which are also safe for women and don't increase the risk of blood clot.
I think the other thing about the implantable devices producing progesterone is that they tend to reduce the amount of bleeding women have at the time when they have a period. So they're particularly good if women are on anticoagulation. Okay, so if we move on, and what advice would you give a woman who you've put on a pill that increases their risk of clotting? What are the signs and symptoms you're going to ask them to think about that they need to be alert to?
Well, so classically at medical school, we were taught that the symptoms of a deep vein thrombosis were a big, swollen, bluish coloured leg, that hurt when you flexed your ankle. But actually, in my experience, many patients present with a history where they feel that they pulled a muscle in their leg, in their calf. And often they might go to a physiotherapist or someone to see about this pulled muscle, but this pulled muscle actually is a blood clot. And I think that's one of the strongest warning signs that I look out for in someone, and I get a woman to pay attention to whether or not they have a symptom like that. And if they do have a symptom of a pulled muscle, especially one that doesn't get better in the usual few hours that it will get better, then it's really important to go and have a scan or a blood test first, perhaps, to look for the D-dimer level being elevated. But if they're a very high risk pre-test probability of having a blood clot, then they need to go straight to having a scan, an ultrasound scan of their leg to see if they have a blood clot. So that's the deep vein thrombosis symptoms. With a pulmonary embolism, the symptoms can be a little bit more difficult sometimes. People describe being short of breath, sometimes being dizzy or blacking out, having chest pain, a sharp, stabby chest pain. Coughing up blood is a rare complication of pulmonary embolism, but can happen. But so critical things would be chest pain with a feeling that you really can't breathe very well, and that especially your ability to breathe when you exert yourself is compromised. So they're the main symptoms that I look out for. But I guess the most important piece of advice is, if you have concerns of any kind, of any symptoms that you think are unusual for you, then you should present to your doctor for further investigations and to explore the diagnosis.
I can't agree with you more about the fact that the surgical textbooks are full of pictures of people with enormous legs that are very swollen, that are obvious deep vein thrombosis. And I think everybody who's had a deep vein thrombosis will probably end up at that stage, but we want to catch them early. And most people just have unexplained pain in the leg. So that is the symptom that should take them along to see a healthcare professional. You have also talked about pregnancy and postpartum being risk factors for having clots. So what advice do you give to women during their pregnancy and the 6 weeks after they've delivered, which we call the postpartum period?
So again, I think the most important thing is to inform women what the potential risks are, and also to explore what their specific risks might be. So in general, pregnancy is actually more pro-clotty time than being on the combined pill. So it makes your blood even stickier to be pregnant. So the changes in pregnancy that will increase your risk of blood clotting is that pregnancy makes you make more clotting proteins and make more sticky blood. Also, the pressure of the uterus pushing down on the veins in your pelvis will slow the blood supply back up through your pelvis, and that's another risk factor for blood clots. So it's the same sort of symptoms that a woman might develop during pregnancy. I think importantly, statistically, more of the blood clots in pregnancy are in the upper portion of the veins in the legs, so potentially more dangerous in terms of developing a pulmonary embolism. The majority of blood clots, about 80% in pregnancy, will be in the left leg, but that doesn't mean to say you can't get a clot in your right leg, so don't just look for left leg symptoms. But again, it's more of exploring with a woman what her potential individual risk factors are. Does she have a family history of blood clots? Has she had a previous blood clot, especially a previous blood clot in association with a pregnancy or being on a combined pill? And then you need to discuss with them whether or not they reach a threshold where you would recommend taking a blood thinner, such as an enoxaparin, a low molecular weight heparin, during pregnancy to minimise the risk of getting a blood clot. Now, only a minority of women need to actually do that. And importantly, probably the highest risk group would be women who've had a blood clot in a previous pregnancy or postpartum, women who've had a blood clot in association with a combined oral contraceptive pill. And some women have clotting tendencies, either inherited or acquired, that increase the risk. So you need to explore those issues further and explore the issue of whether or not a woman has a family history as well. So there's a number of factors. And also if a woman gets admitted to hospital while she's pregnant, then that's a particular risk, especially if she's unwell with conditions relating to blood pressure or infections. Then that's a time when perhaps for a short period of time, the time when she's in hospital, that she definitely would need some blood thinning treatment. And then you talked also, Beverley, about the postpartum period, so the time after the baby's born. And that's probably the highest risk per day for a woman to get a blood clot in association with pregnancy. And that is maybe because she's had a cesarean section or she's had some other complication in pregnancy. But even women who've had a vaginal birth can have a blood clot after pregnancy. So the first 6 weeks after a baby's born are the highest risk per day of a woman to get a blood clot. And that's when women and healthcare professionals need to be particularly alert to something like this happening and take steps to reduce the risk if a woman reaches a certain threshold of having a risk for blood clotting. So it's complicated and there's no one simple answer to give at the moment. But the critical thing is to talk to your healthcare professional about what your risks of a blood clot in association with your pregnancy are and take the best steps for you to minimise those risks.
But I think we've really done pregnancy and postpartum period really well. So let's move on to another scenario. Now, we hear a lot about women on anticoagulants having heavy periods. Is it common? Is there anything that can be done to help?
So it is common. I mean, a blood thinner will thin your blood and will increase your risk of bleeding. And it is a particularly challenging time when a woman is menstruating and she's on an anticoagulant. It appears potentially that the newer forms of anticoagulation, the so-called direct oral anticoagulants, might have a slightly higher risk of causing heavy menstrual bleeding, but this is being explored more to find out whether or not this is just something that is more noticeable. But there are simple things that one can do. A woman could take tranexamic acid, for example, which is something that will make the blood clot firmer, and importantly is not associated with an increased risk of forming clots itself. And the other important thing that you mentioned earlier is the Mirena IUD, or the levonorgestrel intrauterine device, is a really useful tool for women who have heavy menstrual bleeding, because it's a device that sits in the uterus, that releases progesterone, and that stops the lining of the womb building up through the menstrual cycle. So, up to 3/4 of women with one of those devices won't have any bleeding at all. And it's probably one of the most useful tools that we have for women who have heavy menstrual bleeding, who are on an oral anticoagulant. And it can last up to 5 years, so you can keep it in for the duration that is required.
Okay, so we're moving on now. Our woman has had her babies, she's entering the menopause and thinking about hormone replacement therapy, or HRT, because she's got unacceptable menopausal symptoms. What advice would you give her about the risk of clots with the different types of HRT?
So a woman or someone who chooses to take menopausal hormone replacement therapy has essentially two main options that are used for this replacement therapy. First of all is the tablet, which probably the majority of women will take. And also there is a form that's called transdermal, or across the skin, where you wear a patch that's got the medication in it. And the important difference between these two different forms of medication is that the tablet form is associated with an increased risk of blood clots. Similar to the second generation pill, the background risk is increased by 2 to 3-fold. But the transdermal formulation doesn't have any increased risk of blood clotting. So for a woman who has risk factors or is concerned about her risk of blood clotting, then using the transdermal formulation is the best way to start. The important thing when we talk about the relative risk increase, so I mentioned a 2 to 3-fold increase in the background risk. It's important to be aware that as we get older, our background risk of blood clots increases. So rather than the 1 in 10,000 risk that you have if you're a young woman, your risk when you're over the age of 50, 60 is probably around about 1 in 3,000, 1 in 5,000. So you need to factor that into. So when you increase that risk, if your risk is 1 in 4,000, you double that risk, you've got a risk of 1 in 2,000. So it's important to keep in mind what the background risk is. And then the background risk isn't just the general population risk. A woman might have specific risk factors for a clot that might make you want to recommend the transdermal formulations over the tablet formulations. But ultimately, if a transdermal formulation doesn't give you the symptomatic relief that you need, then you need to carefully assess your risk factors to work out whether or not the risk-benefit ratio, or the chances of something bad happening versus you being looked after, cared for well, whether or not that is in the favour of offering the treatment or not offering the treatment. And there will be some women in whom the risk will be particularly high. And I have looked after some women in whom the risk is so high because they might have had a blood clot before, but their symptoms are so severe and concerning for them that what I actually do is I give them a blood thinner or an anticoagulant at the same time as the tablet form of hormone replacement therapy, because in general, that's not going to be a lifetime that they need the hormone replacement therapy for. It's usually a few years, and for many women that can work as an option for them. So it's important to know that you do have different options.
Okay, good. So let's move on to a more modern issue. We have a number of clinics that I'm linked with for transgender people, and many people are in the process of transitioning gender, and they're taking hormones. Can you talk to us about the risks associated with transitioning as far as clots are concerned?
Definitions that are important in this setting will be a female to a male transition, so a woman transitioning into a man would need to take testosterone hormone replacement therapy generally, sometimes with and that taking testosterone in a woman transitioning to a man surprisingly does not significantly increase the risk of blood clots. On another scenario is the woman transitioning, is a man transitioning to a woman, and in a trans woman, you need to take estrogen supplements and occasionally progesterone as well, but generally just estrogen. And just like with the combined oral contraceptive pill or estrogen-containing agents, that does increase your risk of blood clots. And again, it's probably by the same sort of factor as menopausal hormone replacement therapy, as the contraceptive pill. It's about a 2 to 3-fold increased risk. The risk increases with the dose of estrogen that's required, and there will be some situations where a higher dose of estrogen is required to get the beneficial effects that the person is desiring from the hormone replacement therapy. And so in that situation, the risk might be higher. But I think one of the most important things is to consider the general reason why someone wants to take the therapy. There are clearly very important reasons why a man transitioning to a woman will want to take an estrogen-containing therapy, and it is likely that that person might be able or willing to accept a slightly higher risk of thrombosis if a higher dose of estrogen is required for them to have the net desired effect of the hormone on allowing them to live the life and feel comfortable in their skin as they would want to be. So all of those different aspects need to be discussed when you're considering the hormone replacement therapies in those settings. But I think the main takeaway message is transitioning from a man to a woman, taking estrogen therapies. There is an associated increased risk in clotting, but there doesn't seem to be the same increase in risk if a woman is transitioning to a man or male to female.
Excellent. So our last question, what is the number one piece of advice you give to patients regarding gender-specific thrombosis risks?
I think the most important piece of advice is if you feel that you are in a time of your life or an episode where you are at risk of a blood clot and you get symptoms, go and see someone about the symptoms. Don't just wait and see how things develop, but actually take steps to go and find out from the healthcare professionals whether or not your symptoms are a blood clot or something else, because that is potentially life-saving. And that's the most important piece of advice. Blood clots can be lethal, and generally they're lethal because people perhaps have not been so aware that the symptoms that they're having are a blood clot. And before you know it, a deep vein thrombosis breaks off to the lungs and can really put your life at risk. So that's what I would say. If in doubt, if you have symptoms, go and seek advice from your healthcare professional.
Excellent, Claire. Thank you. Thank you for all your expertise and guidance today. We really appreciate your time. For additional information on women's health and gender-specific thrombosis, please visit www.worldthrombosisday.org. And anyone listening in, please stay well. And thank you very much for joining us today.